you've been oncology the whole time. And so your career has been floating through all different avenues of oncology.
As a nurse on the front line for many years, it's changed the story and it's revolutionized cancer care. So that is very exciting. I'm lucky to see those changes.
Well, thank you for being with us today, Natalie Dietrich. How are you?
I'm good. Thank you for having me.
We're going to really dive into the specialty of oncology and what that means and what opportunities there are. But first, can you share with our viewers what your story has been and where your journey has led you?
Sure. Thank you for the opportunity to tell everyone about what I do. I'm an oncology nurse, and I've been focused in oncology as my nursing practice area my entire career.
Mm.
It really was that when I graduated, there were not a lot of job opportunities for new grads. And that seems crazy to think about now as you see so many new grads getting hired to work,
Yeah.
many places, in many practice settings. So it was the opportunity I had. I worked 12-hour nights, and I found that I really liked learning about oncology, and the patients were quite sick.
Mm.
But as I've stayed with oncology because it's very exciting to be in that field, and I've seen throughout my practice from the middle '90s until now, revolutionary changes in what
Mm.
cancer treatment is and what it means for people living with cancer. And every place I've been, whether it was hospital inpatient work or outpatient clinical trials coordination, inpatient clinical trials work.
Mm.
And then as an educator teaching patients and professionals, I've only touched some of what there is to offer nurses in oncology, but I
Mm.
love it. And the career opportunities and the learning opportunities are unlimited. One thing that has really impacted my career is membership in the Oncology Nursing Society. So we
Mm.
can talk about that as we carry on with this conversation. But I would say one of my colleagues recruited me to go to one of the chapter meetings. And, I eventually went. And then I joined, and it has had the greatest impact on my career and kept me in oncology and helped me to try to convince other people or to share with others the benefits of a professional nursing organization and how it can really impact your career in a positive way and help you learn to love and be more insightful and knowledgeable about the work you do.
I actually want to talk about both of those aspects that you just talked about. The first one being with the revolutionary changes of the field of oncology. There's a really negative stereotype that follows oncology where it's a sad specialty to be in. Basically, it's a stereotype of death. Like the patients are sick, they have cancer, they're going to die, whether it's right away or after you get to know them for months. But if that's truly all there is, then it wouldn't be, I think, as great as it actually is from what you're saying, that you love it and you have so much passion for it. If it was only sad, then I don't think you would have been in it for 2 decades. Is that correct?
That's right. So there is a button that people used to wear, and it said, "No, oncology isn't sad." And that really is the truth. It is exciting. It's a very vast array in terms of diagnoses, types of cancer, and there are those very sad cases. But really, what's most exciting is the changes that have come in treatment. Monoclonal antibodies in the
Mm.
90s, changes in the ability to prevent and manage nausea and vomiting.
Mm.
So people can get their full doses of chemotherapy on schedule at those full doses. That's because of changes in the medicines to manage and prevent
Mm.
nausea. So that has changed cancer care and allowed people to get those full treatments rather than being
Wow.
delayed or have dose reductions. So that has impacted outcomes for patients.
Mm.
And that's because of treatment changes, advances, pharmacologic changes and advancements. And now immunotherapies. I jumped way ahead
Mm.
from the '90s to the last decade. But those changes have changed the story of cancer treatment and cancer care for patients all over the world. It's changed the story and it's revolutionized cancer care. So that is very exciting. So I really praise the scientists out there who have helped make progress. But as a nurse on the front line for many years, I'm lucky to see those changes. And it's taken a full journey, inpatient, outpatient, to see those people because, as you know, in the hospital, patients are often very sick in the past
Mm.
and currently. Those are the patients that you see in the hospital. They're very sick. having been an inpatient nurse and an outpatient nurse, and to be able to work with medicines that are new, never before given to patients in some situations, as I worked in clinical trials, you see progress up to today, where when you read people's stories, patients or professionals, what they write about their experience working in oncology or being a patient, stories like you've never seen before for cancers that didn't have good outcomes, like lung cancer, breast cancer. It's very exciting. There are sad moments, but it's very exciting.
You've mentioned immunotherapies, just for the viewers who don't fully understand, because I think the stereotype also with oncology is there's chemotherapy and there's radiation, but you're saying that there's other options for treatment besides just chemotherapy or radiation. There's the medical advances and everything that's happened. Could you explain what the names are of the different types of treatments?
So cancer treatment has historically been about chemotherapy.
Mm.
If you're looking at medications given to treat cancer. So there's chemotherapy, which is not specific to good cells or bad cells, but it attacks those rapidly dividing cells, which malignancies, cancer cells, whole host of side effects on the good cells that are also rapidly dividing. So those have been the mainstay for many, many, many years. And there's lots of interesting stories about how those drugs were used in the past or how they came to be used in cancer treatment. Those are your cytotoxic drugs. This is very general. And then there's monoclonal antibodies in the 90s, started to see treatments for lymphomas, and then also a different monoclonal antibody used to treat more aggressive type of breast cancer, changed the story of cancer care for those patients in those different disease states. Those monoclonal antibodies target specific receptors on cells. So you don't get the same side effects, but they might be given in combination with chemotherapy, which affects good and bad cells because of mechanism of action of the chemotherapy, along with the monoclonal antibodies that are targeted therapies. And then jump way up to the last decade where you see people getting immunotherapy. And those would be drugs that are given to really jumpstart the immune system. Again, very general term, but we know that cancer can trick the body and turn off certain immune responses in the body. So when you give certain treatments, immunotherapy, checkpoint inhibitors, they will jumpstart the immune system. So there are side effects associated with those drugs. But what they can do to help the body fight the foreign invader, the cancer cells, trigger an immune response, jumpstart that immune system, has really changed the story of cancer care over the last decade for populations with lung cancer, for example. So the story has changed. It's been exciting to see all that. Give you very, very general overview of pharmacologic advances, and only a little bit of the pharmacologic advances that go on in cancer care. There's oral therapies that are used more than ever, and those can be targeting specific receptors. Those can also be not so specific drugs that are considered cytotoxic and affect good and bad cells as well. So part of being an oncology nurse is having a good foundation on side effect management and being able to teach patients about these side effects and their families. Because at the end of the day, patients and their families carry a large responsibility when it comes to managing their cancer care.
It really helps for you to break that down. And I know you can go into much more detail than that, but I think that was a really good baseline for the viewers. You mentioned all of the different treatments that are there and side effects, but these are pretty hazardous drugs that we're talking about with chemotherapy and the targeted treatments. What are the general precautions that nurses have to take when they're giving the patients these kinds of medications?
You want to prevent hazardous drugs from coming in contact with those people that do not need those drugs. So nurses use personal protective equipment and it as appropriate for preventing exposure to hazardous drugs. You have your chemo gloves. In the case of chemotherapy, double glove is the standard. Your gown that is not going to absorb anything that would splash. And then you have your eye protection, your splash guard. And here in this era where everyone's wearing a mask and eye shield, we're ahead of the game as oncology nurses and handling hazardous drugs. But it's not just about the oncology nurses. We work collaboratively with the pharmacy where the drugs are prepared in the environment as appropriate. Biologic safety cabinet, for example, with the proper airflow to avoid aerosolization for those who are preparing the medications. You have safe handling guidelines in place, and that includes what I said, the PPE, but also how devices are connected so you would have no dripping when you connect a
Mm,
line or if you had to disconnect a line. And generally, the measures that are taken have evolved over time. Nurses tend to be well versed on safe handling.
mhm.
And yes, there's been a lot of years and a lot of times where you carried that chemo bag without gloves from the pharmacy to your department in your bare hand, not even in a container or ziplocked. Not best practice, but I've seen it. I hear stories. People used to mix their own chemo in the doctor's offices and they'd have their soda can over there and they'd be working under the hood.
Mm,
Those days, I hope, are long gone. I can say that in my work since the early 1990s as an oncology nurse, I've never mixed chemo, but
mm,
I've had plenty of exposure, and there's lots of research out there on exposure just on surfaces in the nurse's station, et cetera. So there's been advances, new guidelines are in place recently or being put in place, and that's all based on USP 800. It doesn't just affect nurses because you think about the bathroom where the patient goes to
mm,
the bathroom in their hospital room or in the clinic bathroom, and they've had chemotherapy, known that there's active drug being excreted, and that
mm.
would depend on the drug's clearance time. So safety is at the front line of what we're thinking about, and there's been a lot put in place to help make our workplaces for everyone that's there safer and reduce exposure, as well as for those patients that go home. Because as you
Mm.
know, largely cancer care is done outside of the hospital setting
Yeah.
these days more than ever.
When we're talking about safety with oncology and treating patients, there may be some settings, like if you're doing an infusion center where all you're doing is administering hazardous medications to patients, but not every oncology patient on an oncology floor will be getting active chemotherapy or hazard drugs. Well, Natalie, you've had such a well-rounded experience in the oncology field and worked multiple different venues and hold so many different roles, from being the floor nurse to being more administration now with education. Could you give us a little more information about what the different possibilities are for nurses, kind of what the pace is of those, typical schedule, kind of give us an idea of what each little picture of different oncology specialty could be?
So oncology nurses work in the hospital or they can work outpatient. They may be working in an area where they're giving
Mm,
medications in either of those settings, or they might be supporting patients because of side effect management or disease
mm,
management needs. Hospitals may have dedicated oncology units now in 2000s. Years ago, I think there were more oncology units that were dedicated for that population, knowing that also you could always get a medical patient,
mm,
a non-oncology patient. Nurses working now in the hospital, I'm sure, can understand about those nursing home admissions that come in with the urosepsis at 2 in the morning, right?
mm,
You get everything when you're
yeah,
on an oncology unit. Even now, there are fewer dedicated oncology units because so much of cancer care has moved outpatient.
mm,
So that means you can work in the hospital, and I see RN new grads starting in specialty areas all the time, including
mm,
oncology. I did that, but I feel like people were encouraged to start on medical or surgical floors,
mm,
you know, years ago,
yeah,
and they still are starting there. But you can start in specialties these days because nurses are needed everywhere in the hospitals.
mm,
Also, as a newer nurse, you may be able to work outpatient. I don't believe that it's a hard and fast rule anymore that you
mm,
must start in the hospital. I know that the hospitals where people start, they get a good foundation. You can get the medical basics down. I say with oncology, you learn all the systems of the body. So you're getting the
mm,
medical foundation, you're learning and putting into practice what you had in school when you're a nurse working in an oncology setting, especially in the hospital.
mm,
In the hospital, you get very sick patients. You may also see that you don't give that much chemo in the hospital because so much is given outpatient,
yeah,
and what you're doing in the hospital is supportive care. A population that you do see quite often in the hospital, especially as they commence treatment with a new diagnosis, are the leukemics, acute leukemics,
mm,
and some lymphoma patients. Maybe it may be because those patients, those hematologic malignancies, not all, but many need to start treatment right away.
mm,
And so they're getting a diagnostic workup. And once there's a definitive diagnosis, they will begin treatment right away.
Gotcha.
So you would treat those patients in the hospital, and maybe it's multiple cycles. They come back, they're there for a month to do their treatment and recover their bone marrow,
Mm,
get side effects resolved, and then they may do their next cycle inpatient or
mm,
outpatient. That being said, oncology is a great practice area when you want to have a really strong rapport with your patients
mm,
and the providers, your nursing colleagues, the team of doctors, advanced practice providers, social work, case management. You all work together in the oncology team. And that is especially true in the inpatient setting.
mm.
You see the whole process in action when you're working inpatient with oncology, the oncology population. So on an oncology floor, throw in those other patients that are in for DVTs,
Mm.
medical admissions because there's no beds elsewhere. You see it all.
Yeah.
So I highly recommend for nurses that are thinking about a specialty area practice change, or they're new in nursing, go for oncology because you learn so much that you will carry with
Mm.
you throughout your career. Enough on inpatient. Outpatient, I said, you can do a lot, you see a lot, and you see people that are living with cancer.
Mm.
They may be healthy people, just like your neighbor next door, had breast cancer or lung cancer, and they're in for treatment and they're out. With treatments now, depending on what type of cancer treatment it is, they may not lose their hair. So you don't even know if you saw them on the street or
Mm.
at the grocery store that they're a cancer patient. So outpatient, you see a lot of treatments. Outpatient, you're going to have a schedule of patients. You might have 6, 7, 8 patients in a day, maybe
Oh,
9
wow.
or 10. Some days the outpatient setting is very busy. I feel like that I remember the times when I worked outpatient. I used to say, oh, today feels like a day starting out where you better go to the bathroom and eat now because you're not going to have time all day long. Just like some of those 12-hour shifts in the
Yeah.
hospital, feel like you never got a break. So outpatient infusion, where you're giving the treatments, still there's a lot of collaboration. I mentioned
Mm.
nurse navigators. Oncology nurse navigators play a big role in patient teaching. There's follow-up, there's care coordination, planning the next treatment. What other things do
Mm.
they need to have done? Are they getting reevaluated for a response to treatment for their disease? Lots going on. Who coordinates a lot of that? Nurses. So
Mm.
there's a lot of roles that are crucial to the outpatient flow of cancer treatment.
Mm. Nice.
There is radiation oncology, where you're working with patients in amazing high-tech setting. Your role in radiation oncology is likely to be focused heavily on teaching and symptom management, supportive
Mm.
care, skin reactions, dehydration, diarrhea, side effects in different parts of the body from radiation therapy, teaching about new therapies, new advances in radiation and what it means for the patient. If you love to teach, there are many, many places for you in oncology. Clinical trials. I said I've done clinical trials. I was a treatment nurse in early phase trials at the NIH, which is the National Institutes of Health Clinical Center
Wow.
in Bethesda, Maryland, many years ago. And we did early phase trials. And we did a lot of, they were inpatients. So we treated them, carried out research protocols as part of what is one member of the treatment
Mm.
team for these patients. Lots of teaching, lots of hands-on, and lots of collaboration with the clinical trials teams. I've done outpatient clinical trials coordination where you
Mm.
are doing a lot of teaching, you're doing the data collection, reporting that to the research organizations through the processes that are well-defined. You're not actually giving the treatments. So again, teaching, flexibility, rapport with the patients. You may meet with them one-on-one in the doctor's office or in your office if
Mm.
you at the hospital. I learned about so many different cancer types working as a clinical trials coordinator. And that is a job where there are so many opportunities for nurses. And you asked about avoiding direct contact with hazardous drugs.
Mm.
Well, clinical trials coordination may involve processing some samples, which isn't something we learned in nursing school. You go to the lab and you spin off your samples and you have to store them, freeze them, and eventually you'll ship them. You learn everything when you're a nurse, right?
Wow. Yeah.
Uh, so you're not in direct contact with hazardous drug.
Mm.
So again, more opportunities for nurses, and research is something that you could have a whole series of podcasts on,
Oh,
or
yeah.
video podcasts, because there's so much to learn. And research is how we've made progress, and we recognize the contributions of patients to help us make progress in advancing the science of cancer care,
Yes.
allowing for better outcomes. There's more roles, cancer prevention roles, especially if you
Mm.
advance your education, you go to a master's degree, you can specialize and find roles in associations that are focused on cancer care. Cancer centers have multiple roles. It's people spend their whole career, like I have in oncology, and change their job function
Mm.
multiple times. And again, the science, the advances are what keeps many people there. And then the relationships with patients, because if you want to have an ongoing relationship, you may be able to follow patients if you're in research for many years as they've had follow-up. Not everyone survives, but there are people who are long-term survivors, and the follow-up is done in part by nurses who are in the research process.
Cancer can always come back. Just because you're in remission now doesn't fully mean that you're cured all the time. And so it's important to
Yes.
follow up and make sure that they know the signs to look for in case it comes back.
When people have a diagnosis of cancer, there's staging and grading, among other things, that are done to determine what is the most appropriate treatment. So there are specific criteria, and those are set through standards, and they sometimes evolve over time in terms of what is the specific definition of a response.
Mm.
So then people during treatment, but they would have a response measured through imaging, or they may have surgery to remove their malignancy, their tumor, or they may have treatment and then be reevaluated with a CT scan or a PET CT scan to determine if there's any disease left or has it shrunk from the
Mm.
treatments they've had. And then the treatment plan would be specific in terms of what will be done to further address eliminating the disease, if
Mm.
that's the goal, or minimizing the impact that disease may have if it's more extensive,
Mm.
in terms of preventing more complications. Technology plays a huge role in being able to evaluate response to treatment, not just looking at images from CT scan, but also from looking at blood samples, and a fewer number of malignant cells, for example, in a
Mm.
sample of blood is something that could be done. And there's a lot of things that are done in research trials to continue to learn more about how to look at and evaluate response. When people are done with treatment, they may say, "What now? Who's going to help me? I had my home away from home, and now who's going to look after me?"
Mm.
Fear or concern about recurrence is a big deal. And there are people who spend their time in research and in practice working with survivors.
Mm.
Survivorship clinics are a place where
Oh,
nurses
wow.
work too. And that is widely implemented as part of cancer programs in community and academic or research hospitals.
Wow.
So you would then give people a survivorship care plan,
Mm.
and they would then know when they were supposed to get imaging, whether it's mammogram for breast cancer patients or other imaging, depending on the type of cancer and what the plan is. So people know when they're coming back to look for or monitor for recurrence.
Mm.
There are recurrences. Disease may come back in the same place. Disease may come back elsewhere.
Mm.
And that's a huge piece of cancer care and follow-up. And we do have recurrences, but they're not always.
Yeah. With oncology, do they typically want you to have any special certification or class in order to be able to safely handle and administer those medications? Like basically chemo medication certification before jumping into handling those kinds of medications?
Yes. So nurses need didactic or foundational knowledge
Mm.
to learn about chemotherapy, cancer care. And traditionally, there have been chemotherapy provider courses.
Mm.
As a member of the Oncology Nursing Society, I had my local chapter in the Washington, D.C. area where we would teach a course, and everybody volunteered, and we were nurses who worked in cancer care to teach different sections of a
Mm.
course. It was a continuing ed course, and it would be on a Saturday and a Sunday, one weekend. It was a big deal. And we would offer it to nurses in the community, and they would get the basics on administering chemotherapy. Over the years, that course evolved, and the Oncology Nursing Society offered a course that was a CE course, and they had trained the trainer models so that
Mm.
the information was meant to be consistent among wherever it was taught, all
Yeah.
over the United States, for example. Then the course evolved to an online course from the
Mm.
Oncology Society, which is quite common over the last many years.
Yeah.
It is widely utilized by hospitals across the country, that the Oncology Nursing Society, or the chemotherapy, biologic therapy provider course is what it was called for many years,
Mm.
is used to allow nurses to earn a provider card that they could present to their employers to show they have the minimum foundational
Mm.
knowledge to administer chemotherapy. The courses now I'm referencing would be, for example, a chemotherapy immunotherapy course. They've
Mm.
changed the name a little bit. 16 hours of content, for example,
Wow.
PA course. That was the didactic piece. And then there would be some type of competency validation
Mm.
in the workplace setting that would be defined by the employer. So that's the education, and then the competency validation. There are many healthcare settings where they have their own course. You would assume they would cover much of the same content that's essential knowledge.
Hopefully.
And for example, the Oncology Nursing Society course has always recommended that nurses have, several months working in
Mm.
the cancer care setting before they take the course. It helps to come in with a little bit of knowledge from being in that workplace.
So getting knowledge of the environment and the specialty before taking the course in order to be handling those hazardous materials yourself, correct?
So it takes a few months to see what goes on and start to learn a little bit about what you're going to be doing in the cancer care setting, whether you're giving
Mm.
chemotherapy or you're treating those patients who would come into the hospital with side effects, or as outpatients needing supportive care for side effect management. So they need some time in the field, let's say, to
Yeah.
get introduced before they would be expected to take this course, because it's a lot of information. And
Mm.
thinking about taking the test, there's always really challenging questions. And it's just the beginning of oncology education. And we are to keep our card current. So I believe it's a 2-year cycle.
Oh, wow.
You have to renew the course with a review class, like a
Mm.
5-hour course, if you're taking the class from the Oncology Nursing Society.
What is your favorite aspect of being in oncology?
It is definitely the relationships that have been built with patients in all of the practice
Mm.
settings I've been in. But it's also the relationships with the people I work with, the nurses, the doctors, everyone else who's on that oncology team as a professional. There's a special level of commitment and
Mm.
compassion that those people
Yes.
exhibit that puts them in the oncology setting or keeps them there. And I also like the relationship with patients, because you do have an ongoing relationship with many, many
Yeah.
of the patients that you meet.
Oncology may not be for everyone, but what advice would you give to a nurse who is considering it as a potential opportunity?
Well, you need to think about, what are you going to learn? The science, the advances in cancer care, the disease states, there's so much to learn.
Mm.
And it is a commitment, because you do need to commit to lifelong learning.
Yeah.
You graduate with your bachelor's degree or your associate degree or a master's, doesn't mean you're done learning. And it is
Mm.
challenging to keep up with everything that's rapidly changing in healthcare, especially
Yes.
in oncology. The new drugs that are approved, it is exciting to see people do well. It
Mm.
is distressing and sometimes shocking to see that people don't do well.
Mm.
But I would say that the positives and the good feelings far outweigh sadness
Mm.
or those distressing moments.
I do want to emphasize, just for the viewers, that every specialty of nursing that you're in, whether it's med surg, ICU, PCU, there are going to be those times where there are distressing and sad moments. It's not that it's solely specific to oncology. And it's really a stereotype that should be across all the boards for nursing and their professions.
Nothing is easy. No job is easy. No practice area is happy, cheery all the time. These are patients
No.
that are coming for care. Nursing is not always going to be positive. There are challenges. But I would say, if you like to be focused on technology, or you want a highly skilled area to practice, multiple IV
Mm.
pumps, amazing devices to give cancer treatment through, and be in an area that is evolving, as quickly as it can be to help make a difference in people's lives, oncology nursing is for you. It's a place to start. And from that starting point, you can go anywhere. And
Mm.
if you decided later to go into a different practice area, you will be valued and sought after for what
Mm.
you've had in your experience working in oncology. I would say, go for the opportunity in oncology. It's a great place to be, and you really can make a difference in people's lives.
Well, thank you so much for being with us today, Natalie.
Thank you so much for the opportunity to share what I love about oncology nursing.
Life is a winding road, no telling where it goes.